Everyone. Good morning, good evening, good afternoon from wherever you are joining from. Welcome to this TBPPM webinar today. We're very happy to have you. We're really pleased to have an excellent panel today. We're talking about the global funds work mostly, and the global funds work in countries, but the title of today's session is Programmatic Efficiency and a Private Sector Engagement in TB Care. As we all know, there is the world is rapidly changing in front of us. We have financial changes around the world, and programs around the world are affected by the finances that are changing, especially tuberculosis programs. So for that reason, we are looking at how can we better streamline and align our work so that we can more efficiently work together within health programs, within government programs at all. So for that reason, we're talking today about optimizing our programs. And one of the key ways is by engaging the private sector. So this is a 90-minute session. We have 5 excellent speakers. We have a Q&A at the end. So if you have any questions, please put them in the Q&A. The chat you can use to introduce yourselves or to say hello to one another. But if you have a question that you would like us to address in the panel, please put them in the Q&A. This session is being recorded. It is also live streamed on YouTube. And if you need to, you can turn on the subtitles for your use. We will be sharing a post after this webinar with all the key messages. We will be creating a report that will be available online, and you can also find the recording. Please follow any of the social media that we have is LinkedIn, Blue Sky, Twitter, and Instagram and Facebook, where you will find further details, and join the TBPPM Learning Network if you would like to know more. So with that, I would like to introduce our fantastic panel that's with us. First and foremost, Dr. Mohamed Yassin. He is the TB Senior Advisor at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. He's based in Geneva, and he has over 25 years actually, of experience in TB control with some excellent experiences at country level. And he is closely involved in many of the countries that have Global Fund grants. So very pleased to have you, Mohamed. Thank you so much for joining us today. Then we do have Dr. Immaculata Kature. She's the National TB Manager in Kenya. She's a leading figure in Kenya's tuberculosis control landscape, combining frontline TB care with leadership and high-level policy strategies. And she has an amazing track record also on supporting pediatric TB. And she will be talking today to share Kenya's stories. I'm giving all the introductions ahead of our panel so that between we don't waste too much time. And you can also find all the bios on our website. Dr. Amy Sarmiento, she's a public health leader with PhilCat from the Philippines. Thank you, Amy, for joining us. Dr. Adil Tahir, who is the TB Program Manager and the Director at Mercy Corps in Pakistan. Thank you, Adil. And Dr. Obioma Chijioki Akaniro, who is the Deputy Director and Monitoring and Evaluation Manager at the National TB Program and Leprosy and Buruli Ulcer Control Program in Nigeria. Thank you all very, very much for joining us today. And with that, I would now like to, as a first speaker, go over to Mohamed Yassin. Mohamed, please feel free to share the screen. Thank you so much, and looking forward to hearing from you.
Thank you very much, Petra. Thank you, everyone. Good morning, good afternoon, good evening. Thank you for joining us for this exciting webinar. I'm Mohamed Yassin. I'm a Senior Advisor at TB and the Global Fund based in Geneva. I'm also the current chair of the PPM Core Working Group. And I will be sharing on creating efficiency and optimizing TB programs by engaging private sector. why programmatic efficiency and optimization is needed now. As you all know, despite the significant progress made in TB response, including through the Global Fund support, especially in the last few years after the huge disruption due to COVID, there are critical gaps in funding overall globally. And we have also seen that over $1.35 billion gap in global fund, the current funding cycle, we call it grant cycle number 7 for critical commodities and other services. And we also understand from several studies that existing tools and resources are not often used optimally and efficiently. That leads to issues with access. And these are the reasons for us to discuss about this program efficiency and optimization. We have done an assessment to better understand the interventions which are cost-effective, scalable, and best practices in the countries to identify options to optimize the resource and the tools as well, so that you can leverage from efficiencies and save, so that we can use that resource for closing the gaps. And this is based on literature review, report reviews, extensive, and key informant interviews with critical stakeholders, including country national TV programs. And I would be sharing quickly some of the key observations we have seen through this analysis. And the colleagues who will be presenting after me will be sharing the detailed country experience, but I would like to highlight some of our overall opportunities as part of efficiency. One is on integrating TB service within TB programs, where we see that like routine screening with a contact investigation and providing TB preventive treatment in South Africa reduced more than $9,000 per daily averted. And in Pakistan, sample transportation helps in diagnosing and improving treatment outcome as well. In Philippines, the integrated DSTB and DRTB are already contributing toward this improving access and better outcome. And in Zambia, for example, integrating chest X-ray with AI and the use of expert improved affordability. In Ethiopia, patient-centered DR treatment at community level and at facility level already contributed to savings. These are some of just examples. There are several more. And the second part is more on efficient use of tools, the algorithms and approach. And some of the country examples include in Pakistan, the use of the WHO recommended rapid molecular tests in the private sector, which improved access and boost utilization of gene experts. And as we all know, most of the countries are now transitioning to the 6-month regimen for drug-resistant TB, which already contributes to savings, but better outcome as well. Again, chest X-rays with CAD, artificial intelligence for reading, sputum sample processing, including pooling of sputum samples whenever there are shortage of cartridge, contributed to improving TB service delivery with efficiency. In Vietnam, combining chest X-ray with AI and gene expert already contributed to TPT, TB prevention treatment. And several countries already moving to more targeted program reviews, streamlining supervision and training, e-learning, and the use of the data, so this could contribute toward this efficiency. The second part is integrating TB and combining with other programs and other services, including TB and HIV, diabetes, hepatitis, nutrition, and maternal and child service already happening in several of the countries, and combining sample transportation, not just for TB, but for other diseases as well, strengthening the use of human resource, including community health workers, to provide integrated service rather than just for TB, and the use of the molecular diagnostic as multi-disease platforms to improve diagnosis screening beyond TB, and integrating supervision, case management, all these service could lead toward this efficiency. And the private sector is one of the options which actually leads to cost effectiveness and savings as countries are involving and expanding innovative private sector engagement models, which already improved access, coverage, also quality of service provided while promoting partnership. Overall, as already highlighted, there are financial gaps. Countries are exploring innovative financing mechanisms for TB, and there are several options to do depending on the country context, and to leverage additional resource from domestic fund, other source, and blended financing, and expanding financial assistance to TB patients and families. But I just highlight the few of the items which are very important for private sector, including integrating TB into social protection and insurance, which ensures sustainability as well, and performance-based financing incentivize efficient interventions and models, and implementing the laws on mandatory notification. But this could also be incentivized so that the providers could be engaged to maintain their engagement. Overall, the optimization and efficiency we put on it to bucket. One is enhancing efficiency within TB. The second part is integrating TB services in other diseases and combining with other programs so that we can gain efficiency. And I've already highlighted some of the examples on integrating and decentralizing TB, including contact investigation, active case finding, and TB treatment and prevention, DRTB and DSTB, and all the digital technologies with the screening. But we reducing the cost as well, while promoting the move from the traditional diagnostic screening methods to more cost-effective and more sensitive screening and diagnostic tools, and cost-effective algorithms and treatment as well, including for DRTB, DSTB, and TPT, and digitalization along the cascade of care, including for reporting. And as you can see, private sector engagement remains as a cost-effective approach for scale-up depending on the context. But the domestic funding, additional resource from domestic funding and other sources, including through innovative financing, remain as a critical component. And integration already mentioned, the opportunities are there to integrate TB with other services, including within the community, where we need to keep empowering the community engagement along the cascade of care, and expanding integrated sample transportation and digitalizing. And all this information available in our report, in our website, which highlight the detailed example. And I quickly want to highlight the global fund investment in the private sector. And as you all may know, that the global fund is the main source of international funding for TB in low and middle income countries. Through time, increasing the global fund contribution for private sector from like 4% to almost 12% of the global fund grant going to private sector engagement, which contributed already, you'll see in the table, that to improved TB notification and the treatment outcome. But we have also noticed that there is a mismatch between the contribution of the private sector to notification, which is over 25%, in some countries reach up to 45%, and compared to the budget allocated within the global fund grant for private sector engagement, which is about 11% at the moment. Also, there is an increase, there is a mismatch. And then this excludes expense related to commodities. And we have done deep dive in few countries on specimen transport, data system, diagnosis, and incentive provided to private sector, again, as part of assessing any good lessons learned. You see, you have done this. We have done this in 6 high TB burden countries, where you can see this is overall epidemiological data. The burden range from 643 per 100,000 in Philippines to 183 per 100,000 in Tanzania, and you'll see treatment coverage already reaching 80% in Bangladesh, and the proportion of patients who are missed from the reporting gradually declining. And also to highlight that in these countries, most patients, when they have symptoms of TB, they first go to private sector, a range of private sectors, including pharmacists, and clinics, and hospitals, up to 85% in Pakistan. And you see the overall, the post-COVID era, the notification contribution from private sector increased from 2021 to 2023, and reaching to over 45% in Pakistan in 2023. Countries also have the access to gene expert testing in the private sector. The data are different, but overall, the private sector facilities now have, some of them have gene experts machines, but most of these are concentrated in public facilities, and there are insufficient distribution of the machines in the private sector, and a lack of responsiveness and capacity in the private and the public sector to accommodate all the samples transported through from the private sector. But overall, this effort is already contributing to improvement in diagnosis, including bacteriological confirmation as high as 80% in Nigeria. And sample transportation happening. Countries are using different actors in sample transportation. Most countries use local motorcycle riders, and you see that the number of riders and the number of samples transported, with average turnaround time from 1 to 7 days, and the cost of less than $2 per sample transported, as less than half cent dollars in some of the countries. On financial incentives, and countries use different type of incentives, including monetary and non-monetary. For the financial monetary incentives, the type of providers also vary in different countries. Its comparison would be difficult. And the service for which incentives are provided also varies. We see a long range of service in Nigeria compared to Pakistan and Philippines. But overall, you would also see the payment for per patient diagnosed and successfully treated from almost $52 to less than $18 in Philippines, and that's why that cost effectiveness component would be critical while incentivizing the engagement. But overall, engaging private sector providers in TB improves coverage, quality, and digital technologies an opportunity to further improve reporting and incentivize private sector engagement. Integrated sample transportation improves efficiency and effectiveness. Access to molecular diagnostic tests for patients in the private sector improve diagnosis and bacteriological confirmation as well. Integration of TB into health insurance schemes enhance access and utilization. A combination of financial and non-financial incentives tailored to country context would remain as a main component which would drive, motivate the providers. The Global Fund support in general has been contributing toward this improved access to notification and improved treatment outcome. And continued support, including from domestic source, other national, international source, including Global Fund, would be critical to maintain the momentum, close the funding gaps, and preventing any service disruption Private sector models in TB could be optimized, adopted, and depending on the country context, could be even more efficient. I just want to highlight that the Global Fund has recently communicated with all the countries which received the funding as part of the Grant Cycle 7 program reprioritization approach that's intended to protecting and enabling access to life-saving service. And we have those core life-saving service, including diagnosis, treatment, targeted active case finding, and TB prevention. Cross-cutting elements are also there. And you can see that private sector, again, highlighted within the Global Fund communication to countries as one of the cost-effective approach. And we believe that this would help countries to maintain private sector engagement activities within the TB program, despite all the financial constraints which we have seen recently. This information is available in our website. I just want to acknowledge my colleagues, Amna, Rashid, and Lisa Kempo, who has been working with me on this analysis, and all the Global Fund TB team and other colleagues. Thank you very much. Over to you, Petra.
Thank you, Mohammed, for such an excellent presentation. Really appreciate you outlining all these excellent examples and lots of data that is relevant for everyone. Really appreciate it. Some very important lessons, and I'm glad to be introducing Dr. Immaculata Katuri, who is the National TB Manager of Kenya. She will be highlighting a bit more of the lessons from Kenya, and she will explain especially how digital tools have been one way of optimizing the work that they're doing. So Dr. Immaculata, I'm pleased to invite you to pull up your presentation and share. And let me see, you're with us, right? Yes, I can see you. Wonderful. You're still muted.
Sorry. All right.
No problem, no problem. Do you want me to share your presentation, or would you want to
No,
share
I'll
yourself?
share on my end.
Okay,
I'll share
perfect.
on my end. Yeah. So as mentioned, my name is Dr. Kathura Immaculate, TB Program Manager from Kenya. So I'll be taking us through a quick presentation on how we have managed to leverage on technology to review our progress, especially at primary care levels, and also how that encompasses private sector engagement, collaboration, and what the future looks like, because I think that is where it's exciting for most of us. So just to give a snapshot of Kenya, and we know Kenya remains a high TB burden. Of course, the last prevalence survey put our prevalence at 426 cases per 100,000. We have seen a rise in case notification over the years. And we also know that as well, we have a high burden for HIV, with 26% of the population who have TB being co-infected with HIV. In 2024 specifically, we had an estimated about 124,000 persons who had TB, of which we managed to notify over 96,000 cases. Of note is the fact that about 77% of the estimated incidents was able to be identified and notified. But unfortunately, we still have 23% of persons that are yet to be notified. For us, that's a very important number, because our best opportunity to identify and notify the missed TB cases is basically working with the communities and at primary healthcare level, where from the last patient pathway analysis, most patients are likely to seek care. Now, Kenya has also surpassed the 2020 TB strategy milestones. We've managed already had achieved 38% reduction in incidence and a 56% reduction in mortality by the year 2020, and currently are well on our way to achieving our 2025 milestones. When we look at the NTB strategy, of course, there is a lot of emphasis on early detection, making sure that we're able to successfully treat our patients, and overall accountability for the program, both to donors and to the population and the community that we serve. For us, the digital tools become enablers to ensure our quality care that we are providing to our patients, and also achieve our NTB strategy goals. Of course, fact check, just for you to know that 95% of TB services in Kenya are delivered through the primary healthcare programs, that is lower level facilities, level 2 and 3, and at the community level, meaning that for us, any digital technology use and enhancement will actually go a long way in improving visibility at that level. Now, just to give a bit of a background on the system that we use for recording, reporting, and management, we have what we call the TIBU. TIBU is a national system that is case-based, that has full coverage across all the 47 counties. We have a system that has been running for over a decade now, starting 2012. And so far, we have over 1.3 million encounters of TB already notified through the system. The system does not just leverage, or it's not just used for reporting, but it also helps to manage our payments. So we have the component that is called TIBU Cash. We have the TIBU LIMS that helps to monitor diagnostics and sample movement. And we also have TIBU Meds that helps to monitor commodity management. So overall, TIBU is a comprehensive system that helps both in case management, notification, reporting, and then financial management, program management, and also the diagnostics and commodity management. Now, the way TIBU is structured, we have systems that run coordinated at national and county level. We have 141 users at county level and over 310 users at sub-county level. That is the TIBU county and sub-county platform. However, to ensure that we improve the use at facility level and extend the same to community level, we rolled out what we call TIBU Lite. That is a facility-based program that is a point of care system to help in patient management, of which we already have 11,700 healthcare workers and over 10,000 community health promoters already using the system to report, and we have over 5,400 facilities enrolled in the system. So what kind of outcome-based monitoring have we been able to do? So when we look at the TBPPM, which is what I would want to focus on today, we have been able to monitor our patient care and treatment, where we have seen the TB treatment success rate so far achieved of 89%, reflecting a strong program performance and effective patient management. This means that as we're improving our ability to report and notify cases, through TIBU Lite, we're also improving the ability of the healthcare workers to notify cases and report and have real-time monitoring of patient progress and performance. And then for the county and the sub-county teams, they're better able to monitor progress and be able to actively identify opportunities to better strengthen and support the facilities. When we look at the time to treatment in 2024, we noted that from the system already we could tell that almost 55% of our notified cases were initiated on treatment within 7 days, with recent improvements pushing this to 58%, meaning that one of the benefits of digitization has been to monitor and improve treatment delays, because then healthcare workers are able to get their results in a timely manner and at the same time initiate patient on treatment. When we look at our ability to monitor our loss to follow-up, we already have through close monitoring, and I'll be able to share with us why this number has reduced to 4.32 across both public and private sector. Now, I'll dwell briefly on the loss to follow-up, because for us, what we did is we integrated use of AI models for analytics and prediction within the TIBU platform, thereby being able to identify and flag patients who are at high risk of mortality and other being lost to follow-up, thereby empowering the clinicians and the coordinators at county and sub-county level to better follow up these patients, significantly reducing the loss to follow-up rate for these patients. For DRTB, we have also had good success with 80 to 83% of patients being successfully treated, with improved outcomes being linked to adoption of newer and shorter-term regimens. What we have seen overall when it comes to quality of care through the system, despite the services being at lower level facilities, use of data and digital technology has helped to improve our supervision and accountability of services at the primary healthcare level. Now, when we look at the private sector, we have as a country implemented what we call a PPM dashboard. This dashboard is able to help us track private facility notifications, thereby notifying us of how many patients have been notified from the private sector. We are able to look at the outcomes by provider. That means the way data is disaggregated in TIBU, we're able to tell how many cases were notified in the public sector and how many were notified in the private sector. And then we are able to differentiate where we need to put in a little more support and help to make sure that the outcomes are improving. Additionally, we've been able to use this to facilitate facility benchmarking, whereby facilities within a county or sub-county can be able to leverage on the information across board to see the performance, where they rank, how they rate compared to other facilities, and thereby being able to improve their own performance over time. We have also used TIBU to monitor other aspects of public-private partnerships, like diagnostic services, where we have the ability to be able to identify which sites are providing what diagnostic services, and then making sure that those are available and the information can be disseminated widely. This means that even in the private sector, facilities are able to refer patients to diagnostic services more appropriately. As a result, we've seen improved visibility of the private sector contribution, with the private sector improving from 19% to 24% in the last 4 years. Now, additionally, we have community data, and before I talk about lessons learned, we also have community data that has been incorporated into TIBU. And as I move to the next, when I'm looking at how the future looks, I'll be able to highlight what are some of those areas that we hope to improve when it comes to leveraging on technology and the primary healthcare model. Now, the lessons we've learned so far is that the TIBU project management system has been key to improve our performance gains, with real-time data helping to make faster decisions both at the clinician, lab, and supervisor and manager level. We have seen strong private public integration, helping to boost accountability and reporting. And then we have had the benefit of predictive analytics and alerts, shifting the focus to performance. Now, how does this look at what the outlook for the coming days looks like? So one of the things that we are keen to do is to implement the AI roadmap. That is where we will be using generative AI and chatbots. We know that most of the times, quality of care at primary care level is affected by the ability of a clinician to make decisions in a timely manner. And for the community health promoters, sometimes it may be a challenge for them to identify what areas they need to focus on. So when we look at using big data and leveraging on generative AI and chatbots, one will be able to query specifically for the area that they're responsible for, query the system to identify areas where performance is not good or where we need to focus on, and then be able to zero in and provide the requisite support. Additionally, related to that is to be able to use predictive analytics, so that at the end of the day, if, for example, a patient is notified today, we're able to tell what is the risk of them being lost to follow-up. We are already able to tell how they are likely to their mortality risk, and therefore meaning that clinicians and the community promoters are better able to support that patient in patient adherence, and also making sure that all comorbidities are managed. What we intend to do is to strengthen the hardware and the connectivity. As we know, the diagnostic landscape is rapidly shifting, so that then we can interoperate with other diagnostic platforms as they become available, but also because most of our private facilities have existing EMRs. So strengthening our system ensures that whatever system the facility is using, Then we are able to plug in and make sure that there is data sharing and reporting that is seamless. We'll also be strengthening the architecture and cybersecurity, as we know, whereas we are talking about leveraging technology all the way from community level, ensuring the security of the patient information is pivotal. And one of the things that we are embarking on is a robust cybersecurity process to make sure that this patient information is protected. Additionally, even as we are looking at interoperability with, for example, digital x-rays that will be used at community level, that data is already being uploaded into TIBU through the TIBU LIMS, and therefore ensuring that that information is safe is paramount for us. The other area that we are looking at is to achieve a national rollout of TB as a POC for TB screening, diagnosis, and treatment. So far, we have users across all the 47 counties, but we've yet to roll it out to each and every TB facility, and therefore that is something that we'll be focusing on doing within the coming days. We'll also be using technology to build the capacity of healthcare workers and community health promoters. We know we are operating in unique fiscal times where the funding is rapidly dwindling, and the resources we have need to be able to stretch to cover healthcare worker capacity building, both in public and the private sector. So one of the things we aim to do is to make sure that we will leverage on TIBU as our go-to training platform so that healthcare workers across both public and private sectors, both primary healthcare and tertiary level facilities, are able to use the system to improve their capacity, thereby cutting costs on our end, but continually engaging and developing the capacity of our healthcare workers and community health promoters. We'll also be using this system to strengthen technology networks for healthcare workers to facilitate remote consultations. We know one of the challenges at the primary healthcare level is staffing challenges, and one of the things we want to be able to do is provide an avenue where healthcare workers can consult across the board, and even those in the private sector, being able to receive real-time consultation and feedback on difficult cases, thereby improving the quality of care, and specifically so as we are looking at management, decentralized management of drug-resistant TB, which is also being managed at primary care level. So with that, one of the things I'd want to say is for us, yes, as a program, leveraging digital technology has been pivotal, is going to go a long way to help improve TB management both at primary care level and the private sector, making sure that there is data that is timely, accurate, and useful to guide decision making at all levels. Thank you.
Big round of applause, Dr. Katouri. That's an excellent presentation, very forward-looking, really exciting to hear you speak about all the different technologies and how you still keep the primary healthcare providers, all care providers, and the people at the center. Thank you so very much for explaining these points, and it's also very clear how these will lead to efficiencies within Kenya. You're really leading the way, so thank you so much for sharing these lessons with us. And please stay for questions. There might be some questions in the Q&A. Please, everyone who has questions for Dr. Katouri, add them to the Q&A. Then I would like to now introduce Dr. Adil Tahir, who is leading the TB program in Mercy Corps in Pakistan. Pakistan has done amazing amounts of work in delivering TB services to many different populations, vulnerable populations, through several mechanisms. And he is going to be talking about the operational private provider service delivery models today in Pakistan. Dr. Tahir, if you can just display your presentation as a full screen, then we are very excited to see and hear you.
Yes. So is my presentation now available as full screen?
We can still, if you go to the top to display settings, and there you click full screen, I think then we will see the full screen.
I actually did it. Let me.
Oh, maybe it might take a little second delay. Right now, yes. Oh,
yes. Okay.
No, sorry. We still see half screen.
Okay.
If you click on duplicate.
It's basically enabled.
Okay. No problem. Then we'll just do it
start.
like this, unless
Yeah.
you want me to display it.
Okay. So thank you, Petra. I'm Dr. Adil Tahir and currently working as the director of the GC7 grant, which is funded by the Global Fund with Mercy Corps, and I'm based in Islamabad. So this is a brief overview of TB epidemiology in Pakistan. Pakistan ranks 5th with regards to the TB burden in the country. Each year, around 700,000 new cases of TB are estimated to be in the country, and we approximately identify 500,000 of them, where that means that we miss 200,000 TB cases each year. If we talk about drug resistance TB, so estimated incidence of DRTB is around 15,000 cases, of which 4,600 cases were lab confirmed in year 2023, as per the WHO Global TB report. There were unfortunately 47,000 TB deaths in the year 2023. As mentioned by other speakers, in Pakistan too, 80% of the population have their first line of contact with a private healthcare physician or a doctor. If I talk about the scale of PPM in Pakistan, currently Mercy Corps, with the support of 6 partners, is implementing this GC7 grant in 120 districts of the country, and the population of these 120 districts is around 190 million people. Mercy Corps is directly implementing in 26 districts, well, with the support of 6 sub-recipients or partners. We are implementing this grant in 94 districts. The models that we are implementing, the main and the biggest model is involving private general practitioners. Currently, we are working with around 15,854 GP clinics or doctors. Then we also involve private hospitals. So at the moment, we are working with 514 private hospitals in all these 120 districts. We also do active case finding through organizing chest cam in far-flung areas to reach to the population who have no access to health services. Currently, we have 40 mobile vans that are equipped with digital X-ray machines with AI software, plus gene expert machines for the on-the-spot screening and diagnosis. And we have added 25 portable X-ray machines installed in small vehicles that are also used for active case finding. I will discuss in detail in later slides. And we have a robust digital system of transporting sputum samples, which is present in 104 districts. If I talk about private sector contribution in total national notification, so you can see from year 2020 onwards, the notification from private sector is continuously increasing. And at the moment, we are contributing around 47% of the total country's notification, which is around 235,000 TB cases each year. So what worked well, why the private or PPM is working? So I'll explain these in coming slides. As far as the budget is concerned, against the budget of 21% in GC6, our contribution was 36%, which has increased to 47%, as I mentioned in my previous slide. The patient that reach to the private sector, they have their first choice of reaching to a private doctor because of the time convenient to them, as most of the private providers also practice in the evening, while in government sector, you don't have this kind of liberty. Minimal investment is needed to engage a private provider. All we need to do is to train them on national guidelines and sign an agreement with them. A very minimal incentive of around $3 per case is given to GP in 2 installments, and that basically is to promote sustained engagement. Similarly, only the cost of diagnostic for screening or diagnosing TB are covered through our program. The remaining costs are covered through the patient, so it's kind of a mutual kind of relationship. The treatment coverage is only limited to anti-TB drugs or TBT, while the cost of ancillary drugs, if a doctor prescribed, that is being borne by the patient themselves. Similarly, through this intervention, we have a field team that are continuously conducting contact screening through household visits of all the bacteriologically confirmed TB patients. and that gives us an added advantage of finding more TB cases, plus identifying a high-risk population, and we offer them TB preventive therapy to reduce the risk of progression to active TB. Specimen transportation model, we have introduced this model in around 2020, and this is a digital model that is managed by an Android app, Rider for Health, and a central dashboard. So instead of sending patients to the diagnostic facilities, we transport sputum samples. We take the samples directly from GP clinics or private hospital and transport to the GeneXpert site or microscopy centers. The system is detecting or providing information real time and giving us diagnostic updates for all the TB presumptive patients that are accessing our health facilities. Since January 2024, which is with the start of this current GC7 round of funding, we have transported around 476,000 sputum samples, and we detect around 70,000 DSTB plus 1,774 RR cases through this system, which is available or which is working in 104 districts of the country. And the average cost per sputum sample transported has reduced gradually over the years because of the model. It's just $1 per sample. Around 400 riders are involved currently in this system, which are not on our payroll. They are basically community volunteers, and this also gives them an opportunity to earn their livelihood with the support of this system. Another important thing that worked really well so far, and we are hoping that with the complete rollout of this intervention, our work will be more efficient and more cost-effective, which is digitalization of our recording and reporting system. All the tools that we use in TB are now being digitalized using DHIS2 tracker system. And this enables us to generate automated reports, case-based record, and real-time dashboards. So this boosts an efficiency in our system and also easing workload to all the staff members that are involved in our program. We plan to integrate with our active case finding software, which is ECBS, and our specimen transport Riders for Health application. Thus, a complete care point of care system will be established right from the identification of TB presumptive till the time that treatment is completed. This system also supports deduplication of the cases, better planning, and optimized use of resources, because the staff, they are now free to focus on other program implementation areas rather than just filling the recording and reporting tools. We have a force of like a trained staff force which can use this system and also can customize dashboard according to their needs. We also have developed a PPM Hub, which is Pakistan's national platform for case management and patient support for live case reporting, as well as timely ensuring timely guidance for patient and their families. So if any patient or their family have any questions regarding the treatment of the TB or availability of the services, they call to free helpline number, and then they can talk to the call center agent in their own local language and get the information. Another important thing that I really like to highlight is our active case finding intervention. As I mentioned, we have a fleet of 40 mobile vans plus 25 portable X-ray machines. We conduct around 500 to 600 chest scans in a month and detect around 1,200 to 1,400 new TB cases through these chest scans. These chest scans are placed or organized in areas which are identified through a Match AI platform, artificial intelligence driven, with the information of around 70 indicators. That includes the literacy rate of the population, the nutritional status, the poverty status. So based on these indicators, the system generates an hotspot, and then we organize a chest scan. This system or this intervention also helps us in advocacy. So before each camp, we directly communicate with the community notables. We raise their awareness about tuberculosis and tell them that what would be the benefit of timely diagnosis. Although in terms of cost, this seems to be a costly intervention, but it is in the longer term, it's a cost-effective intervention. If we talk about reaching to the population that do not have access to TB, through this intervention, we interrupt the cycles among families that are having a TB patient living among them. So early diagnosis is possible. And then in terms of Kuala and Delhi, this intervention is highly cost effective. So ACF, our active case finding intervention, not only save lives, it's also reducing long-term cost by preventing advanced diseases and hospitalizations. Now I'll talk about some way forwards that we want to bring into our system, and we are already working on these. The first thing that I mentioned already is the full digitalization of all the recording and reporting system, plus integration with different applications that we are doing. And this becomes the whole PPM model, a very cost-effective solution. Then further improving cost effectiveness, we are planning to pilot certain new diagnostic tools that are cost effective, and thanks to the Gates Foundation grant, we will soon implement this. We also want to expand our GP network. As I already mentioned, we are working with around 15,000 general practitioners, and we want to expand this network to around 18,000 by incorporating more than 3,000 more GPs in our system with the same staff members or same workforce, because now the digital systems are in place and the load or the work on the staff is distributed. Enforcing mandatory TB case notification. The law is approved in Pakistan, but its implementation is not to that extent. If that happens, then it will be an added advantage to our PPM network, or it will help us in involving more and more private providers in our system. So we will work on that with the support of national and provincial TB control programs. Then incorporating our specimen transportation model to other disease programs such as HIV, and integration of our active case finding with other disease programs. So within the same chest cam, we can screen patients not only for tuberculosis, but also for HIV, for hepatitis C, and diabetes mellitus, which are very prevalent diseases in our country. Incorporating our TB program with national health insurance schemes such as Sehat Sahulat card, which is a government scheme in all the provinces of the country, and also incorporating our TB program with social protection schemes such as Benazir income support program, so we can help the populations or the people who are at risk of developing TB, not only with the timely diagnosis and treatment, but also helping them to enhance their nutritional status, to enhance their social status, thus they can defeat tuberculosis. And finally, the most important thing that we need to work is ensuring domestic resource mobilization. At the moment, yes, there are domestic resources, but we need to enhance more and more domestic resource mobilization, particularly in this area where funding constraints are prevalent. So these are the things that I wanted to share with you, and thank you all for patient learning. Thank you very much.
Thank you so much. Thank you so much, Adil. An excellent presentation, some very grounded operational mechanisms that really show how we can better serve our people in Pakistan. But I think the examples that you have shown are very relevant for other countries too. And they're so well described with data and with detailed mechanisms. Very comprehensive, really appreciate it. Thank you, Adil. Please stay on. I'm sure there's going to be questions in the Q&A, so please have a look at those. And I would now like to move on. We're going to the Philippines, where it's already late in the evening, and I'm very appreciative of Amy Sarmiento, who is joining us. She's the Executive Director of PhilCat. Amy, if you want to take us through the work that you're doing in the Philippines and showing some of the PPM initiatives and the engagement of various providers with the work in the Philippines through mandatory case notification and many other key mechanisms in the way that you are leading in the Philippines. Thank you so much, Amy. The floor is yours.
Okay, thank you very much, Petra, for inviting me here. And I would really be glad to share our experience in the Philippines as far as private sector engagement is concerned. Personally, I've been doing PPM since 2001 for 20 years, and we have had several models of PPM, but this time we are doing mandatory notification, focusing on individual private doctors. I will be sharing my screen now. Okay, so what I will be sharing is the experience of the Philippines as far as mandatory notification is concerned. Um, we have three legal bases for private sector in the Philippines. One is Republic Act 10767, which says that all public and private centers, hospitals are mandated to notify their cases, and they shall follow the national protocol. That is the one written in our manual of procedures and what is there in the plan of action. The second one is there is a department order by the Department of Health, an administrative order stating the guidelines on how we will be doing mandatory notification. This is a very, very detailed guidelines which we follow whenever we advocate for mandatory notification to all the private hospitals, the facilities, and our private physicians. So here specified as how we will do data collection, analysis, and how we will be reporting the cases from diagnosis up to the outcome of treatment. And we also have 11332, that tuberculosis is one of the notifiable disease in the Philippines. Yes, please. So our coverage really is wide, no? All over the country. We are working in 18 regions of the country. We covered all the 57 highly urbanized cities in the Philippines, the 63 component cities, and we have around 8,920 notifying physicians from various facilities across the country, and we are working, collecting reports from 4,522 facilities in all the 18 regions in the country. We have a process now when we do mandatory notification. The first one is during the preparatory phase, what we do is map the facilities, map the hospitals, map the doctor. And then once we map all these facilities, the physicians, what we do is invite them to an advocacy forum and orientation where we discuss the manual of procedures, the 6th edition of the government, the Department of Health, teach them how to do screening, diagnosis, referral to treatment, and reporting of outcome. Then we also discuss how mandatory notification will be done through ITs, and what is the legal basis for mandatory notification. So we all do this for the advocacy. So we need the cooperation of all the physicians and the facilities that we have mapped. So that's the first step, advocacy forum, telling them about how they will do the things and what is the basis for mandatory notification. Secondly, once we have already mapped all the physicians, the facilities, what our PCNOs do is go reach out to each of the private physicians that we engage, tell them how to give them an IT's account which they will use for notification of TB cases. Then we tell them where to refer their patients for expert testing. There is a zoning, We tell them about the location of all these RTDL sites, which is around 965. And then for the initiation, we tell them that there are two ways they can initiate treatment. One is treat them privately or refer them to the DATS facilities, public and private. And we give them a directory of all these facilities where they can refer their patients. After a year, we ask them to notify the treatment outcome, including those who completed, got cured, got lost, and all these things. So this is done monthly. Notification is done monthly. Our PCNOs visit, the notification officer will visit each of the private physicians provide technical assistance on how they will notify TB cases, how to refer, where they should be referred, and reporting of treatment outcome. And the last phase is the monitoring. So what do we do for monitoring? So we all have this data in ITs. So what we do is look into the performance of each of our notification officer assigned in specific areas. We have around 210 notification officers. Then we also do an analysis of the city performance. And then we also do an analysis of the regional performance as well as the overall performance, which we report to Global Fund. Then we have introduced a patient tracking tool where our notification officer would list all the patients notified for the month, and then follow up the initiation to treatment, referral to expert, and then after a year, the outcome of treatment. We also do program implementation reviews as part of our monitoring process. We invite our stakeholders, the hospitals, the private physicians, the rural health units where patients are referred for treatment, the public sector. Then we discuss the performance of the project at all levels, and then we try to find out from them what could be the solution. So whenever we do something, address the gaps, it's a joint addressing of gaps by all the stakeholders. So one of the things that we also do every quarter is a joint monitoring visit to the various facilities that we have, to the sites, discuss with them sustainability. We tell them that the project will not be there all the time, so we need sustainability, like designation of a notification officer within the hospital, so that in the future, once the project is done, notification will be done by the hospital notification officer. So we do advocacy to the medical director of the facilities to ensure that after the Global Fund project, the mandatory notification will be sustained. So we also have this enhancement initiatives, which we introduced sometime in April 2022. In the Philippines, there are only about 965 facilities where they can refer their patients to for gene expert testing. This is not enough. So we have problems about access. So what we did under the Global Fund project is to establish what we call RX Pass, where patients can be referred for free X-ray and free sputum collection, and the samples are brought to the 965 RTDL sites for testing. We give a voucher to these physicians. They are attached to the RX Pass, and whenever they want, they have a presumptive TB, they will refer it to the RX Pass. So as of RX Pass really contributed to increasing expert testing, and our experience that of the total expert tested, 11% passed through our RX Pass. Another initiative that we have is the Physician Incentive Scheme, where we recognize the contribution of our physicians, private physicians. So we give an incentive whenever they use expert as the primary diagnostic tool, and another incentive whenever they report the outcome of treatment of the patient, which is really very important. So these initiatives, the RX Pass and the Physician Incentive Scheme, ensures the quality of notification, because in the beginning, we really have difficulty improving the quality of notification. Yes, we have many cases, but then the quality is not that good, Sometimes with the outcome of treatment is not reported, and patients are not referred to for gene experts. So we put in place all these enhancement schemes. And we also introduced a patient tracker tool used by each of our 210 PCNOs. So whenever there is a case notified, they write it down in the patient tracking tool and track down whether this patient was referred for expert, whether the patient was initiated to treatment, and then after a year, we will try to follow up the outcome of treatment. So this is a record that they keep each month. And at the end of each month, what the PSENO, our notification, will do is consolidate the data, find out where these patients are referred, and then follow up the patient's referral to ensure that indeed, everything, it is accepted and it is recorded in our information system. So this is a very, very good tool to track down each of the patients notified by the private physician. So this is being maintained by our, what we call, the private sector engagement notification officers. And then our performance, this is what we are really very, very proud of. In the early days in 2018, we only have around 37,000 cases notified. And through the years, it has increased and it only went down in 2020 during the COVID time. And we were able to recover from 2021 onwards. And now our latest report is around 148,000 TB cases notified by our engaged private physicians. And what is really important is to try to find out to what extent the private sector engagement here in the country is contributing to the national TB notification. So here is the red ones you will see are the notification from the private sector with the total notification. So currently there are around 544,000 cases notified overall in the country, and out of that, 24% came from the notification of the private physicians. So this is something really very, very important to try to find out to what extent private sector engagement is contributing to TB notification. And we have really proven that indeed, if we engage the private sector, we will be increasing the number of notified cases. It is expected that around 30% of the cases are coming from the private sector. So for now, we are already getting as much as 26% of cases from the private sector. There are also other initiatives. So for the Global Fund, we were really able to achieve the target of Global Fund. And this is our latest report. This is what we call our pulse check. So every month we do a pulse check from the PSENO to the province to the city and to the region, and this is the overall. So for this, the last one report is for Q1. We have notified around 34,000 TB cases from our private physicians, and we are really improving as far as expert testing is concerned. 69% were expert tested, 28% bacteriologically confirmed, 75% were initiated to treatment, 73% were there's an outcome of treatment for 60%, and this is the treatment success rate. And for self-encoding, which is the sustainability, where we ask the notification officers or the physician themselves to really do the notification without the assistance of the what we call the private sector notification officer, which is deployed by Global Fund. So this is our latest report, and we do this every quarter. From the PSENO, down up to the overall, the national level, and the national level is reported to the Global Fund.
Last minute.
Here, as you can see that we're really doing well, So our improvement here for the expert testing, initiation to treatment, and outcome is really improving as far as there is now quality, not only the number of cases. So what we are doing now is working with the PMA, the Philippine Medical Association, to help us really strengthen mandatory notification in the country. So this is the first TB Summit, and we have several forums with the Philippine Medical Association at the local level, and we also had the second TB Summit. I think that's all, and I'd like to thank you all for allowing me to share our experience in engaging the private sector in the Philippines.
Thank you so much, Amy. What an excellent presentation, and really powerful to see how you're using the legal tools of mandatory notification to really push progress forward, and to see that you've already in 2024 received 26% of private notifications. Wow, that is fantastic. So close to the 30% target as you have. So really well done. Fantastic work. And thank you for presenting to us. And please stay on for any questions, because I think what Philippines has to offer is way beyond the mandatory notifications. There's a lot more interesting initiatives and lessons learned from the Philippines as well. So thank you, Amy, for presenting. I'm moving on to Dr. Obioma from Nigeria, who is with us. She's representing the national TB program in Nigeria that has been really affected by the recent financial changes, and yet is really sustaining through with a lot of great ideas about domestic financing and sustaining the work that's going on, especially with private sector engagement. And Obioma, I'm not going to give you a presentation, so I will stop talking and I will hand over to you. Please go ahead, Obioma, the floor is yours.
Thank you very much, and thank you for this opportunity. My name is Obioma Chijoka-Kaniro, and I'll be presenting on sustaining private providers in hub and spoke model in Nigeria. I will start by stating that the hub and spoke model has been a game changer for us in the country. And it works this way, where you have a private facility that is able to render full range of TB services working as a hub. Then you have the referral entities that will serve as the spokes. These referral entities are either the patent medicine vendors, the community pharmacists, the traditional birth attendants, the standalone labs, as much as possible. But we do it such that you have, each hub would have like 10 or more spokes that are feeding into it. It's important to us because we've discovered that in some communities, especially within some geopolitical zones, that a lot of people in the population will prefer to seek care first within these entities, within the community. And it serves such that we are able to harness the presumptive that seek care within these entities. Especially, we know that this people seem to be trusted within the community, and also most of them serve a long time, and some of them have been working maybe in a formal sector, retired nurses, before starting up as these entities. So engaging them within the country helps us to improve the access to TB services for the population. I will also start by saying that Nigeria is high burden for TB. It's highest in Africa. It has or contributes about 20% of the TB burden in Africa, and also 29% of the mortality due to TB in Africa. Of course, we started the private sector engagement a while ago, but we didn't succeed so much in it. But noting the fact that 60% of Nigerians access care in the private sector, it became worrisome that we should do more in terms of contribution, as the country had plateaued on within 10 to 14% in terms of the contribution. A situation analysis was done in 2010, and that situation analysis was to just say, what do we do extra to help the private facilities to contribute more? Part of the suggestion from that was the need for us to even give them commodities, some logistical support for them to be able to pick up in terms of identifying these patients. But even with that, up to 2019, we still didn't have an improvement in contribution. So the story changed when we also changed strategy, and that involved having an intermediary organization, which is usually a non-governmental organization, help us with this engagement. And that's basically because the national program, being public, may not understand all the language of the private provider, which is profit-oriented. So having this intermediary organization help us in terms of collaboration, engagement, and officiating different communications and arrangement that led to signing of an MOU, listing out roles of different parties, the three parties, both the intermediary organization, the national program, and even the entity itself, and listing out who should provide what really helped in terms of engagement. We learned a lot of lessons, but most of it is stakeholders engagement. The engagement matters, and how you engage, who you engage, and the platform of engagement is very important. The fact that all things might not be interpreted by you, you need to get help when there's need for help. also played a role. So the governance and even bringing in the umbrella bodies of these associations also helped us in terms of reaching out and getting a lot of them to have this conversation with us. We also instituted different things like ensuring that some labs, people walk to the labs, some standalone labs, to go test. They don't even go through the hospital. So ensuring that these labs also serve as referral entities were part of the lessons we learned. Then instituting screening, OPD screenings, having data management mechanisms such that we can have simplified tool, real-time tool deployed within these facilities, and also negotiating for the incentives and enablers. Of course, we did cost benefit analysis where we looked at to see the minimum addition we should make to what they do, just to have them allow our patients to access services without cost. So all this came into being for us to have this establishment work well. By 2020, just a year after that, we saw the contribution jump from 14% to 20%. And even the presumptive identified by the private sector jumped by more than 200%. And at this point, we had just engaged just a little above 30% of the private facilities in country. So it was just like a wake-up call that definitely there are things we are doing well and we should continue this. But I would also like to put it out here that during COVID in 2020, the pandemic and all the lockdown and the challenges of the health system, I can categorically tell you that the private sector strategy helped the National TB program to withstand the pandemic and also have a lot more of our patients within the community access care. Of course, they could reach the referral entities within the community. Of course, they could be referred to places where they could get their treatment. And at the end of 2020, the private facilities or the contribution from the private sector increased from 17,250 to 35,865, increasing by just about 18,000 patients. And on the total, the case notification of the country increased by 15%, and that's by having additional 18,000 plus patients. So we can categorically tell you that during the storm of the pandemic, the private facilities weathered the storm for the National TB program. Another thing we learned was a private standalone lab. In 2019, we had tested or done a pilot by the Minister of Health presenting, you can see the picture, GeneSpart to a private standalone lab. And just within a quarter, this standalone lab had topped the number of testing, became the highest testing platform within the country by testing 2,160 presumptive with just one 4-module GeneSpart machine. We knew that, of course, we're leveraging on so many things within this, the conducive environment, the infrastructure they already had as an entity, the dedicated staff, the 24-hour working environment and all that, and even creating demand by themselves by ensuring that they have a sputum or specimen collection mechanism within the facility. And it showed that, of course, that as a country, we should do more in terms of engaging the standalone lab. As I talk to you now, we have almost 100 standalone labs with these testing platforms, and they have formed a buttress or even a buffer for the program during labor strike, industrial strikes. We are sure that we can just refer our samples to these standalone labs and still have our patients assess the tests and also treatment. Most of all these things I say are all within the 10 key action, WHO 10 key action for effective PPM implementation, both the stakeholders, engagements, the incentive, and ensuring advocacy, allocating for all of them are within there. So the lesson we learn is us, we practicalizing and seeing that we need to work more with these, our partners, collaborate with WHO, other agencies who are also supporting us to see that this implementation is taken up to height. The successes we had from this PPM engagement led us to include it as a full objective in the National Strategic Plan. And I can tell you that within the National Strategic Plan that we targets for PPM, I can tell you that within the National Strategic Plan, we had put 35% contribution for PPM for 2026. And truly, we are seeing that this is possible, especially almost 33% of our patients are being contributed from PPM. So this is a graph showing what we have done so far as a program. You can see that in 2024, we had 33%, having almost 104,000 of our patients being contributed from the private sector. And out of the 405,000 TB cases we identified as a program, out of 405,000 TB cases, we had about 40,000 patients contributed from the private facilities. And this is a big plus, showing us that from where we are now as a program, that in 2026, we definitely will be able to reach 35% contribution. And probably by the next NSP, which we are planning to come up from 2027 to 2031, we may just have to improve or increase the targets we have for PPM strategy. I just want to draw our attention to this pie chart. This is showing the different contribution to the PPM case contribution. So each of these provider types are all contributing to the larger group of the PPM contribution. But you can see that the patent medicine vendors that are embedded within the community are giving us more than 50% contribution. And if you look along it, you see that even in 2023, we almost had 60% contribution from these patent medicine vendors, showing that for every country that have these people embedded within the community, it's really a big plus to have them as parts of those to collaborate with. I also want to show that the treatment outcome has been fantastic, that even in the private sector, that we have about 95% of our patients treated successfully. That the treatment outcome within the public and the private, you're not seeing any difference in it. That shows the fact that the collaboration, the hand-holding, the capacity building to ensure proper case holding of our patients is working in the private facilities. Now we are in 2025. 2025 also hit us, but not with the pandemic as we had in 2020. But the 2025 hit us with
Obioma? I think we're having some technical issues and we lost maybe Dr. Obioma by phone and by laptop. My apologies. Sometimes technical hiccups and connections, even though we're all wonderfully digitally connected here, and thank you all for being here.
Okay.
We lost your presentation, Obioma. Are you still with us?
Oh, yes, I'm there. I think it was hanging. Okay, I'll just reshare. Apologies. Apologies, I'll just reshare.
No problem. Maybe you
Okay.
can
Or can you share for
round
me
up the
from there?
last minute.
Okay. Okay, so I will just speak to it. The slide is taking time to share. I'll just speak that with the stop work, the USG stop work, and also the funding landscape changing with the Global Fund, part of what we did was to do a rapid assessment for the USG, the implementation and what they do for us, and also look at the Global Fund reprioritization. And within the reprioritization, we just checked on the patient pathway. We looked at, I have a picture here on the patient pathway, a cascade. And what we did was to look at the important components, things not to jeopardize with in terms of this pathway. And within it is helping us in terms of the reprioritization. And part of that is what brought up what we have done. Part of what we have done, one is to ensure that engagement of the private facilities go on, but the form of it is the fact that the referral entities take less investment. So with the resources available to ensure that the referral entities, we still have engagement of the referral entities. While we also ensure that in terms of diagnostic optimization, that we pull a lot of our specimen to the TB lab taking more patients in terms of throughput, and also in terms of cost less for the test done. So gradually we have looked at, I wish, Petra, you can share it so that they can see some of these pictures, my presentation. But gradually we have been able to see that having a lot more of this presumptive pull into the TB lamp, which is more cost efficient. We've also reduced the number of cartridges we buy for GeneSpart, and even that we buy for TrueNat. And by that, we're able to have some savings to redirect to other things we need to do in the program, especially as it has to do with this private sector engagement. And we have gone from looking at the PPM, the TB lamp implementation, contributing from 1% of the tests going to 22% of the tests. So about 22%, I'm in slide 18, 22% of the tests or patients yield comes from the True TB lamp platform as of now. But we have a caveat in it. And the caveat is the fact that children, PLHIVs, and also retreatment cases should go directly to the GeneSpart or TrueNat platform. Of course, we know reason why we had to institute that. The next slide will show that we now follow up this to ensure that the efficiency we are trying to drive is going on. We just want to be sure that on zonal level, are they compliant with this particular algorithm that we have released? You can see from this that apart from North Central, a whole lot of the zones are picking up in directing a lot of their presumptive to the TB lamp platform. So the North Central zone is the zone that we are particularly working on now, and we are sure that in the next one quarter that they should have improved in this. So the next slide is what we have done with specimen transport. The specimen transport is pulled together. Instead of transporting every day, you can transport 3 times a day and having it pooled. And by that, you'll be able to save some funds and also introduce efficiency. Then next to it is the efficiency we've introduced in terms of our 10-color XDR platform and also LPA. Instead of buying the same quantity for LPA and 10-color, we now buy less for LPA, knowing that a lot of our machines have been upgraded from 6-color to 10-color, and that the patients are able to access these 10-color machines. And by that, we're able to do the first line and second line DSC, just having a few of our patients now being sent to LPA. Then finally is what we do with our virtual training, which is the next slide. We have now launched a virtual training platform, and in the last 1 year, we trained about 4,000 healthcare workers on a refresher training. And with that, you can imagine the resources required for that refresher training for 4,000 healthcare workers. These are healthcare workers that have been trained last or had their training 10 years and above last. So there was need for a refresher training. This platform helped us to train them, self-paced training. Also, within it, we're able to introduce all the new initiatives in the program. It could give them issue certificates to them. And we had a mechanism of also repaying them for the data or the internet they use for that. By that, we also introduce efficiency. So on the long term, which is the next slide, is the sustainability plans we have. We've started what we call contracting. Government contracted the non-governmental organization. One was signed last week for the TB program, and we've seen a few. We are trying to see how it's going to go. We're also integrating TB into the National Health Financing Platform. Just like the health insurance, a pilot which we have done with the Global Fund is going through evaluation. And with that, we've been able to include TB into the guideline for basic healthcare provision fund, meaning that within the next steps, we should be able to start assessing insurance for TB patients. The private sector engagement, we're taking it to another point where we are looking into other things apart from funding from the private sector, but looking at things like having dot clinic within industrial organizations where a lot of people work. By that, we can reach the population at work, which we can't reach in the community, especially the male population, which we are lacking as a program. We've also done some kind of integrations, redistribution, where we have TB, COVID, EID, hepatitis tested on GeneSpart. We follow up every quarter as a program to also see that this integration, that we are not having a specimen from the TB program left behind. Meanwhile, we are also ensuring that we carry out the sister program in terms of their testing for the EID and hepatitis. And finally is our digital tool for screening, which we are all harmonizing. We have plans to harmonize all the digital tools in one place so that we can introduce efficiency instead of having fragmentation of tools in terms of community, private sector, but to have all of them in the same platform, use the same funds in servicing the maintenance of the tool. Thank you very much for listening, and thank you for giving me the opportunities, and apologies for the little hitch in the network from my side. Thanks.
Thank you, Obioma. If we could all be so efficient and fast talking as you, we would get so much done in terms of efficiency and optimization. I'm handing over to Mohammed to take a few questions for the whole panel. Even though we are at time, Mohammed, I want to give you the floor and try and harness some of this amazing experiences from countries.
Thank you, Petra. Thank you all the presenters. Really excellent experience sharing opportunities to share with everyone what the country is actually doing, given that we all are operating in a very difficult situation, especially in financing that globally. But the hope that countries are already optimizing, adopting, evolving, and incorporating innovation, and that's what we have seen, all the innovation and private sector engagement, and we have also seen how those innovation investments are already contributing to this TB response in countries, and we all are hoping that this momentum will be maintained, even if there is overall globally funding constraint. I think it's not really to summarize, but there are questions related to overall implication of these international funding reductions recently, including from Global Fund as well and other donors, and how the countries are already mitigating the impact of that, including domestic funding. And you have already highlighted some of the experience. And given the private sector may not be the top priority with the public funding, and the question here is, how are you going to make sure that those innovative interventions, the experience you have shared, will be maintained despite the funding gaps, including through innovative financing, as you have also highlighted, including blended financing, the insurance mechanism, some questions asking if there is any country examples on insurance. Indonesia and Philippines are good examples. We understand Pakistan is moving towards that. Other social protection and insurance would be the way forward, given the reduction in funding and other competing interests. So that's one area overall. How are you addressing or mitigating the impact of the reduction in funding overall? But one other issue which already highlighted Immaculate from Kenya, the issue related to data. While we are really moving towards more AI, digital technology, and so on, how can we maintain confidentiality? And already responded to that question in the chat, but maybe good to clarify how you are managing on the data, real-time data. That's a direction, use of AI on that one, and our overall integration, including bringing more activities to the lab technicians who are already overburdened, for example. It's a trade-off. How can we balance that integration efficiency with the workload, which is country-specific issue? Maybe these are quick questions I have seen in the chat. Most of them were already addressed, and some of them will be addressed later on as well. But if you have any additional comment on those areas, and if there is anything missing, I would like to give you just 1 minute to each of you to reflect quickly. Maybe you can start with Obioma, who was the last, now the first.
Okay, thank you very much for this. I believe, and what I always say is that private sector is very important for the program and very important for the countries. And I don't also want countries to see it as a second option in terms of PTB programming and in terms of reprioritization and aspect of funding, a dwindling funding landscape. It should not be treated as a second option or where attention is given in terms of reprioritization to the public and private sector becomes an add-on. So it's important and to give attention to the private sector and know that equal attention to the public and the private sector is important because there are people you may not or never reach within the private facility. And we also risk the aspect of generating a lot of drug-resistant TB in the private facilities because they will always treat their patients. They will always treat whether they have the capacity for the TB or not. And you can be a breeding point for drug-resistant TB if they are not engaged. So looking at how much it will cost for drug-resistant TB treatment and the fact that it's a lot more expensive, you will see that you're not even introducing efficiency by cutting down from what you do in the private sector. So I believe the private sector should always be given, it should be at the front row in any discussion that is being done when it has to do with TB. Thank you.
Thank you very much. That's coming from the National TB Program. Amy?
So what is very important is really to sustain the initiatives that we have been doing, and really the contribution is very good. But I'm very confident that despite the limited funding, we can still sustain all these things and even increase our performance, so do better as far as the quality is concerned. And we can do this by really doing like online supervision of our notification officers at the field. We do it now twice weekly. And I'm also very confident that the private sector, if you only let them understand the importance of their participation in our effort to eliminate tuberculosis in the country, they are willing to really put in resources also for the private sector. Like, for example, in the past, we've been doing establishing DATS facilities, and after 15 years, they're still there. They're sustained. They were able to sustain their operations from the PhilHealth package, which is now increased. It's around 7,500 pesos for every patient that is claimed for PhilHealth. So we will try to encourage all these facilities to really do the same as what the other facilities are doing for sustainability. And we will try to strengthen the relationship between the hospital and the individual private doctors practicing in the hospital to make a notification more easier for the private physicians, because we understand they have not so much time doing all this notification. So we really advocate for the designation of a hospital notification officer. And perhaps in the future, we can see how this can be, how can they be paid from the UHC funds. Now we will try to connect them, the healthcare provider network. Now we will see how we can connect each and every private sector physician or the facility, because there is that initiative in the country. So this is the future plan of the project, to really look into how we can integrate this initiative into the healthcare provider network where there is funding from the health insurance. So that is our way forward.
Thank you for confirming, for optimism and for the opportunity, as you highlighted. The insurance mechanism is already there that would ensure sustainability. Thank you very much. Over to you, Adil.
Yeah, thank you, Mohammed. And as all the participants are talking, there is no doubt that private sector can contribute to increased notification, and it has proved its importance. But with public sector, I think integration is more important. There are certain areas where public sector can play their part, particularly when it's about talking to other government stakeholders and involving insurance schemes and social schemes in our program. Secondly, I like to say that we need to continuously try and pilot new interventions which are cost effective, so the cost of diagnosis is reduced and cost of screening is reduced. And thirdly, in a country like Pakistan or maybe in other countries, local manufacturing of drugs and diagnostic, I think we should also look for the opportunities in this regard, so that our dependence on import of drugs is reduced, and this will save lots of funding and particularly in the scenario of funding constraint. Thank you.
Thank you very much for highlighting the engagement of private sectors beyond service providers to ensure that local manufacturing would be an option to reduce the cost and efficiency. Thank you very much. Last one, Dr. Immaculate, Kenya, including assuring the on confidentiality on data.
Okay. All right. So thank you. And indeed, thanks to my colleagues for very insightful presentations. I think I have taken quite a lot as we are leaving this discussion as well. Now, for the data confidentiality, as I alluded to it, the way the TIBU system is structured is that providers are only able to access the level of data that is relevant for them. So if a facility is logging into TIBU, they can only see the patients that are within that particular health facility and can only be able to undertake functions that relate to the level of care. So if in the lab, you can only access the lab component. Then if you're a clinician, you can only access the clinical care components. Additionally, for the sub-county and county levels, they're only able to access data for their respective areas of jurisdiction. Now, the other thing that we have is there is non-disclosure agreements that have been signed with all the system developers and the people that help to host that particular data, with backups structured such that we have backup also physically at the program offices. The program leads all the development work to ensure that ultimately, once the work is done, then we also hold the key towards granting access to external users when it comes to granting access. Now, looking forward, I know the funding, as mentioned, has significantly reduced, and the private sector becomes a pivotal area of engagement. So apart from engaging them for TIBU and ensuring that they are reporting and recording, we're also strengthening the lab referral networks to make sure that they incorporate private sector providers and they also know where they can refer their patients for care. Additionally, we are looking to leverage the corporate sector because for us, the private sector goes beyond the private providers. We have currently undertaking discussions on development, be leveraging private sector and corporate investments, and then making sure that when those investments are available, they are also used to strengthen services in an accountable and clear way. So making sure that at the end of the day, we are also leveraging the private sector resources to be able to strengthen the TB agenda amidst the dwindling funding. Then finally, the other area that we are looking to improve on is to transition from paper-based to paperless reporting, both across the public and the private sector, so that wherever a private facility has a digital system, then we make sure that we are able to plug into their EMR. If they don't, TIBUlite is available on phones, tablets, laptops, and computers, which means they can be able to report irrespective of the digital devices that they're able to access, ultimately saving our costs for printing and then digitizing our training content so that then we no longer need to convene meetings for training, but rather have that done digitally as well. Thank you.
Thank you very much. That digitalization would incentivize the private sector engagement as well, including engaging corporate. That's where we expand the engagement of private sector in both the service delivery, but beyond service delivery as well. Thank you very much for sharing all the excellent experience. Thank all the audience for staying so long and for active participation, the chat and the question and answer. Apologies again for taking a little bit longer time. But I would like to use this opportunity to thank all the speakers, but also thank you very much, Petra and Joel and all the team who have been working for a very long time in organizing this excellent webinar and supporting all the activities on today as well. Thank you very much, everyone. And we all look forward to continue working together in making sure that we maintain the momentum in TB response. We know that new tools are in the pipeline, innovations are also there, even if we don't have more money, but we can use the available money, available resource, available tools more efficiently, optimally, so that people could access the best available tools and treatment wherever they go, whether it's in public and private. So we are moving toward this to people-centered approach, and collectively, if we synergize our efforts and investment from domestic source and other source, we would be able to address the gap in TB, accelerate TB diagnosis and treatment prevention, including drug-resistant TB, TB, HIV, and TB is everywhere, and everyone is at risk. We all are breathing the same air, so that's why everyone should take their role in addressing the TB. And that's why public-private partnership would be critical and shouldn't be excluded as part of prioritization, as this would be one of the most cost-effective intervention. And we have seen all the proof for that, innovations and country experience. Keep pushing toward this ending TB and toward this more resource for TB while integrating TB with the whole health system and other programs and activities as well. Thank you very much. Over to you, Amna. Thank you all.
I'll take
over to you, Petra, not Amna.
No worries, no worries. I'm thanking Amna and Lisa for leading the wonderful report, Mohammed, that you were able to share. And the Global Fund has been amazing in recently putting out some excellent guidance materials. So that you're putting Amna in the spotlight is very much appreciated. So Amna, here's a little heart to you for all the fantastic work that you've done behind the scenes. And I want to really, there's not much I can add to all your incredible leadership that you've shown. The fact that we have 2 national TB programs really looking so incredibly forward-looking in the way that you work in Kenya and in Nigeria, and being inclusive of all the private sector in a way that is really showing results is amazing. Please keep pushing in that way. And 2 intermediary organizations that are doing the on-the-ground operations, Adil and Amy, both of you in Pakistan and in Philippines, fantastic results, excellent programs that you're showing away with such comprehensive operations, really, really exciting. I so much appreciate all of you being here on today's webinar and showing the way forward. This is, as you are saying, Mohammed, your closing was hard to repeat, but you're showing innovation and integration and really forward-looking ways in action. And it couldn't be done better than the way you did it today. So we are very pleased to be able to share the recording, share the reports. We will make all the presentations available. We'll also do some small clips and share that on social media, because all your messages are crucial in this time where we're trying to prioritize what needs to be done in a TB program. So thank you all. We will follow up. We're planning to dive deeper in some of the issues around specimen transportation, for example, because a lot of questions came up today from the lab side. So we're hoping to do in August or in September a special webinar around specimen transportation. So stay tuned for everyone who's interested in this topic. More will come, and looking forward to talking to everyone. And keep in touch. Give us feedback if you have anything that you'd like to hear or see, and see you next time. Happy rest of the day. Goodbye. Thank you, everyone.